Welcome, everyone. Our guest today is Adam J. Starr, MD. He's a Hansjörg Wyss Distinguished Professor in Orthopaedic Trauma.
What's the J for?
Huh?
What's the J for?
Jehoshaphat.
Oh, really?
Right,
Awesome.
okay.
He's a
Yeah, I had no idea.
I was going to say Jefferson, and I was wrong. So you're the Distinguished Professor in Orthopaedic Trauma at UT Southwestern Medical Center, Dallas, Texas. And you're also the Medical Director for Orthopaedic Surgery at Parkland Hospital. Is that still the case?
That's still the case.
Just checking.
Oh, man. That is
As far as I
punishment,
know.
huh?
Yeah. So Adam Starr specializes in treating trauma, pelvic fractures, and post-traumatic orthopedic conditions. Dr. Starr, it's such a cool name, Adam Starr. I wish I'd been called like Max Power or Johnny Hercules or something like that. So you've basically been at UT Southwestern since 1988. About right?
That's right.
Thank you. Just do call me out if I cock it up, because I do sometimes.
No, that's right. That's right.
So basically, Pete, this is great. He went on to earn his medical degree at UT Southwestern. He did his internship at UT Southwestern. He did his residency training at UT Southwestern. And then where did he go for his fellowship?
UT Southwestern?
UT Southwestern. And as far as I can tell, the only time you've ever left UT Southwestern was to go to Norwich, of all places.
Yeah, I love Norwich. It was the first taste of freedom I'd had in years.
Of all the places to go, I mean, there are more exotic places around than Norwich.
What was the Norwich experience like? What was it like out of it?
It was great. We our residency program. It's actually a funny story. So
Tell us.
oh gosh, maybe I guess four chairmen ago, the chairman of our program was good friends with the chairman at that time of the Norwich program. They were both interested in total joints, and they met at the academy, I think, and over beer and pretzels, they said, "Hey, wouldn't it be great if the American residents from the Dallas program could go and spend some time in Norwich?" And the first guy to go over to Norwich was a shoulder surgeon here in town named Buzz Burkhead. And Buzz is
Buzz Lightyear.
Buzz is a legend here in Dallas. And Buzz went over there, and honest to God, Buzz, by the end of his time there, Buzz was doing like a nightly radio show in Norwich as a DJ.
That hospital radio type thing.
Yeah. So it was a fantastic experience for us. We would go over there and spend 3 months and live in Norwich, and they're busy. The NHS system, the Norwich Hospital is very busy, so we would operate a lot, and it was good stuff. And we did it it ran for decades. And the thing that killed it was Brexit. The visa ability to go over there just went away. So we lost that a couple, however many years ago. The first set of votes around that happened. So now the residents go to New Zealand. We set up a deal with a program in New Zealand, which is pretty cool too. So, but Norwich was a lot of fun. It was a great deal. I still have friends, people that I met over there. It's fun.
We'll have to set up a link where you send guys over to where we are, Raw London and Whitechapel.
Yeah.
The only thing is, there's probably more guns in Whitechapel than in Dallas.
I'm not sure about that. Probably not, I think.
We'll come back to that. Just to finish up your I haven't finished the intro yet, Adam, please. You've been on the faculty at UT Southwestern since 1997. You spent much of your career pioneering minimally invasive percutaneous treatments for fractures of the pelvis, and in particular the acetabulum. You and Dr. Charles Reiner invented the Starr frame, #own the reduction, for the closed reduction of significantly displaced pelvic ring and acetabular fractures with all the associated benefits of perc surgery. And Pete, isn't your LinkedIn profile photo you with the Starr frame?
It needs changing. Needs changing. But
it's
yes,
like
that
30 years old.
That was me in the old Parkland OR, just putting together the frame on a mocked up OSI table. Yeah.
Awesome. So, Dr. Starr, you have published 100 papers or so, book chapters, books in trauma and pelvic and acetabular surgery. You're a member of the AAOS and the OTA.
Have I really done 100 papers?
And book chapters. I added those in as well.
Yeah,
and books.
He's throwing in some
Yeah,
posters and
Yeah,
I
77.
think you're
77
fudging
papers.
my numbers.
It was
Huh?
70. It was 77 papers. But if you add in the book
Yeah, there you
chapters,
go. That sounds more like it.
a bit of financial doping. It's all good.
Yeah, that's okay. Whatever.
So,
Happy to be here.
you've been named a Texas Monthly Super Doctor and a D Magazine Best Doctor every year since 2009. Are you still in there in the D Magazine? Just wondering.
I have no idea.
'Cause
It doesn't really. It's
a super doctor. What is a super doctor?
you're looking
Yeah,
at it
think
right there.
Yeah, right there.
if you can bench press your weight, you're a super doctor. Yeah, those things are nice, but I'm not really sure what they what they bring, and so probably not something I should worry a whole heck of a lot about.
Yeah.
No, I just thought if you'd been in their charts like since 2009, you'd be like Whitney Houston. I will always love you, top of the charts for like 30 years.
That's possible. I'm a lot like Whitney Houston.
The other thing is you're the Hansjörg Wyss Distinguished Professor in Orthopaedic Trauma. Pete, do you know who that is?
He was a big deal in Dallas. That's about all I can remember about it. I was going to ask Adam about that. What's
So Wyss, Hansjörg Wyss, he's still alive, and he is the guy who he basically owned Synthes in North America, brought it over. He was the businessman who was really instrumental in bringing Synthes to the U.S. and Canada, and so of course he worked at it for decades. And he made and then he ultimately sold it to J&J, and of course made a fortune, made billions of dollars with the sale. And with that billions of dollars, he has turned into probably one of the busiest American philanthropists. So he's given hundreds of millions of dollars to American medical centers. I think his donation to the Harvard system is the largest ever donation to an American medical system. He gave him like $200 million or something exorbitant like that. So
wow.
he gives money to environmental causes, and he's a big environmentalist. So he's actually a pretty cool guy. He's very like you can't call him on the phone. You can't meet him. He's a little bit reclusive, but he's still very active and busy. I can't remember how old he is, but
he's 85.
some of the guys, some of the guys that I know here in Dallas that were, that are sort of first generation AO devotees in Dallas, they know him. Yeah. And
you ever met him?
Huh?
You ever met him?
No, never met him. Never met him.
Wow.
He gave the money to our department probably 15 years ago, and it's an endowment of money that just gets handed down. When I retire, somebody else will get it. But it's a pretty cool deal. So we use that money and set up a meeting, an every other year meeting that Pete came to this past year. It was a lot of fun. We're doing it again in 2022.
Well, his net worth is 8.7 billion, so I'd probably ask him for a bit more.
Yeah.
Get a pay rise.
Yeah, well, good luck.
Send him an email.
Yeah, but no, he's given away. If that's what he's got left, then that means he's given away probably close to $11 billion.
Wow.
Because I think he sold Synthes for like 19 or something like that.
Wow.
So that means he's given away a lot. So it's pretty impressive. You don't see that very often. So it's pretty cool.
No, what's interesting, I didn't realize, was that he's kind of considered one of the left-wing billionaires. So he's very pro-Europe, very much pro the benefits of immigration. And interestingly, on the whole, most billionaires tend to be quite right-wing in their views, by all accounts.
Yeah, I think you're right about that. I mean, I haven't ever met the guy, I haven't talked to him, but if you look at the targets of his philanthropy, that makes that's right.
Climate change and all these things. Yeah, impressive.
Yeah.
So the aim of this podcast isn't really to interview you in like a Frost Nixon style. We're just going to talk to fun and interesting people and shoot the shit. I think that's how you say it in Dallas, isn't it, Pete?
Something like that.
So you spent time there, Pete. Tell us about your time in Dallas.
Dallas was, so whenever you go to one of these other to another country and kind of properly embed yourself into, Chloe came with me, and we had Thea who was about 10 then, and Chloe got pregnant while we were out there, or just before we got there, so we had $100 baby. In Parkland Hospital.
Well, I saw a photo of it. There was a photo up on the wall.
And Chloe was terrified that because they have this system in Parkland where they put all the babies in like this big carriage type thing.
Yeah.
When they want to give the mums a rest, they stick them in. It's like a sort of it's got little partitions, like a little trolley,
Okay.
like a 6-pack kind of thing,
Yeah.
where you put a baby in each one. And Chloe was just had this terrible paranoia. It was going to get mixed up with one of the other babies, and they'd give her the wrong baby, or like.
You said, "I'll have the pasty ginger one."
That's right. Yeah. Honestly, there was no chance. They were basically all Mexican babies.
Yeah.
There was no chance on earth this baby was going to get mixed up. But there you go.
Yeah, good that you didn't come back with Juan Carlo or something.
But the cultural change is like seeing how people, for example, celebrate Christmas, how they celebrate Halloween, which basically in Dallas is like a 24-hour full-on sugar fest. It's like carbohydrate plus sweetathon.
Right.
It's just absolutely fascinating just seeing how people who you think are very similar to you actually they celebrate life very, very differently. And one of the striking thing was that we kind of that hit us quite early on was you realise how London's actually not that friendlier a place. In Dallas, people were unbelievably welcoming and friendly and eager to please and just couldn't do enough for you, which wouldn't have been the case if we'd been Americans coming to England. You really have to earn people's trust and all of that.
Like an American werewolf in London. Type thing.
Yeah.
No, awesome. So you were there for a year, right?
We were there for a year.
And
yeah,
I think
it was a happy year. It was a really happy year.
Is it fair to say it shaped a lot of your philosophy?
Yeah, of course it did.
Managing
Of course
trauma?
it did. Yeah, absolutely. And another thing that really impressed me personally was the standard of the North American, or at least the Texan residents. They were incredibly strong. We'd been given. There was apocryphal stories in the UK, which I think people still say that the American residents aren't very good at operating. They're very over supervised, and they've always got an attending or a consultant present, and so they're not that strong. And that just totally did not turn out to be the case at all. They were incredibly competent.
They could talk the talk and walk the walk.
Yeah, exactly. They were just a really impressive bunch. I'm sure that's still the same, Adam.
Yeah, I'd say in response, I would say that the welcoming sense that you had. I mean, that Pete I could say everything that Pete said about his trip to Dallas about my trip to Norwich. I mean, it was the same way. Norwich it's not a small town, but I'm sure if you live in London, you think of it as a small town, but it's very rural. And so the people were super nice. The registrars were great. There was the senior house officer on my firm lived in the flat below me, and he used to bring up food for me that his wife had made, just super hot. I never knew exactly what I was eating, but it was great. So it was really a good time, and the people were very nice, and they got a kick out of having Tex in there. I mean, they really loved that.
Yeah. Did Heidi go over with you?
Yeah. We went out to a pub and met. One time we were at this out in the countryside. We stayed at this little pub, and there was this tiny little guy there who sidled up next to me at the pub and said, "Where are you from?" And I said, "I'm from the U.S." He goes, "Whereabouts?" I said, "Texas." And he says, "The last Texan I met was a B-17 bomber pilot who could roll cigarettes with one hand." And he said, can you roll cigarettes with one hand? And I said, "No." And he goes, "Well, I guess the U.S. is slipping." But it was, I think, travel like that is great. That's the best part about it.
It is.
Seeing a different culture.
So the thing is, you've created a real legacy, right? It's fair to say you've probably trained a whole generation of trauma and pelvic tablet surgeons over your time.
Yeah, at this stage, yeah, it's true.
And what was the goal when when the fellowship was first set up? What were the aims?
Well, Charlie Reinert is the guy that trained me, and Charlie set it up. Charlie had fellows. I was a fellow with Charlie.
Right.
And so I just perpetuated it, just carried it on. Charlie retired a couple years ago, and we've just carried it on. So he was the guy that got me into this stuff.
Yeah. And Charlie's legacy. I mean, I guess it's still there now, even though he's not part of the. Is he still part of the staff, or is he fully checked out now?
He's got a emeritus. He's listed as an emeritus staff. But yeah, you're exactly right. I mean, we talk about him all the time, and so many of the faculty, the trauma faculty, all of us were trained by Reiner, and so we all have memories and stories. And you talk about a footprint that a surgeon has on a generation of people. The funny thing about Charlie is if you he really had two phases of his career. He went to the University of Texas undergrad, and then went to he was in the Navy, and so Charlie was in the Navy for about 25 or 26 years, and then he got out, and then he came to UT Southwestern to work at Parkland, and he stayed there for 25 years, and then he retired. So he was only in two places, but if you talk to the guys that he trained in the Navy, it's exactly the same. He has exactly the same. There's exactly the same kind of legacy and lore about Charlie with those guys. So I constantly bump into these Navy surgeons or retired Navy surgeons who know that I work at Parkland, and they say, "Did you know Charlie?" And they'll have story after story about Reiner when he was in the Navy. So it's really pretty cool. I mean, he's had a huge impact on orthopedic trauma training in the entire country.
And he had that. The reason he's, because I've ruminated on this a lot about, what was so inspirational about Charlie, because he was still on the staff when I was there. So it was Adam and Charlie when I was there, and Charlie was getting older and he was winding down a little bit, but he was still very much a presence clinically. And he's got that combination of being slightly gruff, slightly difficult to please, slightly, slightly scary, if I'm honest, kind of outward affect, yet at the same time he's got this incredibly warm, almost loving and extremely loyal side as well. So that if you can crack the outer shell and get to the sort of sweet stuff in the middle,
soft center,
and then he welcomes you, and he's just an incredibly warm, loving guy. But at the same time, he's a little bit gruff and hardcore, which kind of just makes you want to please him.
I mean, I met him very briefly. We had a nice chat because he was telling me about his kind of 300-acre ranch down the, and how he had all these cows and longhorns and all these kind of things. So was there? I don't know if I imagine this. Is there a painting of him somewhere in the hospital?
There is. Yeah, it's we put a painting up in our department library, and Dr. Buchholz, who Pete also met. When Dr. Buchholz, we put a painting up of him too, and he said, "Oh, that's the wall of paintings of old dead guys." and then Dr. B, passed away a couple years ago, so he was right. But I guess surgical departments are filled with paintings of old dead guys.
So
we're all headed that way, one way or the other.
Well, I saw this really fascinating painting.
Have you commissioned your painting yet?
No.
But I saw this painting and I thought it kind of looked like Randall and Mortimer Duke. And I said, "Who's this guy?" And they said, "It's the gentleman standing behind you."
Okay.
But he was lovely, actually. He was charming. You must with pride see people, your fellows, go on and become, on the podiums and doing great things.
Yeah. Really, that's one of the very best parts of the job. I mean, the beauty of what we do is that you get to work with really bright, really motivated people who have a lot of energy and want to do good things. And if you have good teams, they don't require a lot of management. They go on and they do the right thing. You can teach them and you can show them how to do stuff, and then they take care of themselves. And it's pretty incredible. I mean, you get to watch people do things that you would never have dreamed of doing, and and so it's really gratifying. It's a lot of fun.
Yep.
So it must be, you watch Pete now go forward and, do his
God,
own
here
thing.
we go.
And, Pete spread the gospel, and that must be one of your biggest disappointments, seeing how Bates is just not developed and kind of just faltered.
Yeah, we're hoping for the best. No, but,
I'm surprised you came on, to be honest with you. After he's tarnished your reputation. It's like being the guy who invented Ebola, I'm responsible for Pete Bates.
He Venmoed me $100 to show up. So I think that, we had Ishii over here this past year.
Yeah.
And so Ishii, of course, trained with Pete. And, it was really cool because Ishii talks about Pete in the same sort of tones that I would talk about with Charlie. It's the same sort of, you have a guy that's teaching you a ton that you look up to and you can learn from. And really that's probably the best part about academic surgery. I mean, I don't know if that exists in internal medicine or other specialties, but in surgery it still does. And so I think that's really one of the coolest things about what we do.
Yeah. The apprenticeship and the relationship for me, I agree.
I must say, Adam, what does pay me, I have to admit it here, is that as a residency program director, I have at least 3 or 4 residents who come up to me and say, I go, what do you want to do as a career? And they go, I want to be like Pete Bates. And I'm like, is there anybody else? Surely.
Yeah.
But so you've certainly set the mold.
Cash, tell us about your visit to Dallas.
So I went, it was 2014 now, Adam. I spent 6 months in the States doing my Winston Churchill Fellowship, and I was lucky enough to meet you at Parkland. I've still got my cap. Let me put it on here.
There you go. Nice.
There it is.
I wear this cap a lot. Generally, Jory Klein gave it to me. So it's my Parkland Memorial Level 1. Here it says standing ready 24/7, 365.
That's right.
Chloe's still got her Parkland T-shirt that says "Proceed until apprehended" on it.
Really?
Yeah.
Where did she wear that?
It's from the 2009.
No, she wears it for like cleaning?
No, she wears it in bed.
Oh, hello.
She wears it in bed.
Hello.
And it's like because it's so old now. It's quite really soft and comfortable and a bit threadbare. But we got
just
that
like
at the 2009 roast, which was awesome. We had it outside and we just had the baby, and it was that was a really memorable moment.
What do you wear in bed, Pete?
T-shirt and pants.
Oh, pants. Okay, thank you. Just checking.
T-shirt and pants.
Just checking. No, we had a great time there. You kindly arranged me to go to a baseball game for the Texas Rangers.
Who won?
The Rangers won, and I basically just ate plastic cheese fries and drank a big gulp because I was in sort of diabetic coma.
That's all everybody does. That's what everybody does.
But the thing is, I'm a big fan of American history and culture, and literally one of the biggest world events ever is the assassination of JFK.
Of course it is, yeah.
And I literally got to, I went to Dealey Plaza, I stood on the grassy knoll, I went to the book deposit, the repository, where there's no way in the world Harvey Oswald shot him from there. The car's going away at an angle. There's 2 corners. It's a complete conspiracy.
You could talk about that all day.
Yeah.
Our former chairman, Bob Buchholz, believed that it was a conspiracy as well, and you could talk to him about it. You could just
talk
kick
all
up
night.
and talk about it all day.
Well, if you're on the grassy knoll, he's coming straight at you. You've got a clear shot. I mean, you're trying to shoot from like 200 yards away on an angle. I don't believe it. But anyway, do you know who shot him?
Well, I don't know who shot him. I think Oswald probably shot him. It's not a 200-yard shot. It's more of about a 30 or 40-yard shot.
Oh, okay. For you, it's easy for you.
Well, yeah, from the window. Well, easy for anybody. So the window that he was in, there's a big oak tree that's in the way now, but that tree wasn't there in 63 it wasn't there when he got shot.
But it was a moving car as well. So, you've got and there's a wind speed. There's various things you got to calculate, right? Yeah,
but you could do it.
Okay. The thing that was amazing was that there was this plaque marking trauma 1 in the hospital, saying this is where the resuscitation happened.
Yeah, that's right.
Yeah. So we're in a new building now, and so that building, and I'm honestly not sure what they're going to do to it because I think it's a historical landmark. So I'm not sure what they're going to do. They're going to have to do something with the site. But it may get knocked down, but they'll always have to have something up there.
Is the building still standing, the old building?
It is. Yeah, it is.
Okay. I never saw the new place. I mean, I saw it, but it wasn't open at the time. It looked amazing.
Yeah.
And the other thing that struck me that you'll remember, Pete, there's armed guards everywhere, and there's a police station in the basement of Parkland.
Yeah. That's right. Yeah, so internal police almost. Yeah, that's right.
Right. Yeah, you need that.
You totally need it. You totally need it.
It scared the hell out of me.
Shit happens there.
Yeah. So we were doing a round, and I remember there was basically 5 gunshot wounds or something with you. And I said, look, what's this all about, Dr. Starr? I don't get this. Why don't you guys just, if you didn't have guns, you wouldn't have this. And then you said to me, have you ever shot a gun? And I said, no. And you go, come with me. And we basically jumped in your car, and you drove me to Ray's Sporting Goods.
In your scrubs?
Yeah.
In our scrubs. And then we were in there with these guns in our scrubs with all these kind of massive shotguns and assault rifles and things. And I was just looking at it. I never held a gun before. And I accidentally was pointing it at the sales guy, and he dived out the way. He was like some former paramedic or something. And
Yeah.
And you're into your guns, right?
Yeah, I used to, when I was a kid, I used to hunt and shoot a lot. And I don't really do it much at all anymore. I enjoy tinkering with them, building stuff and mostly just working with your hands. But I hardly ever shoot anymore. I used to a lot when I was a kid.
Because I'm sure when I was there with you, I remember you taught your son how to shoot squirrels or something.
Yeah.
And you would do something. Sorry, go on.
It's a good thing to learn how to do. It's something you need to be familiar with.
Gun discipline.
Gun discipline.
Yeah.
Yeah, for sure. We teach the residents the rules of firearm safety. There's rules that were developed by a guy named Cooper, who was a World War II vet, and he developed all the basically gun safety guidelines. And so every call day, every other call day, you'll have somebody who gets shot. And so we go through those. So the residents, even if they don't know anything about guns at all, and a lot of them don't, by the time they've gone through the residency program here, they'll know about gun safety. So that's good. They're less likely to shoot themselves in the foot.
Yeah. Same thing happened to me though, Cash. Like, I was about a month in, and one of the radiographers just said, Peter, I'm going to have to take, he took me shooting. His name is Joe. Is Joe still there?
Yeah, he's still here. He's doing great.
Yeah, so great. Joe took me shooting, and he took a real, he saw this as a real project. I got to take Peter shooting.
It scared the shit out of me. I knew there was going to be a recoil, and I had like a handgun of some sort, and I shot it, and the recoil, I knew it was coming. And it literally flinched, closed both my eyes.
Yeah, it's a real thing. It's a real thing. It happens to everybody.
How are things in Texas now? You guys have had a rough time.
Yeah, COVID numbers are down, which is great. So there were a lot of sort of shifts that we had to make in operating room access and bed utilization and all that, and we're drawing down from that now. So that's all good. And then you guys probably heard about the recent the cold weather we had and the ice storm and snow and all that, and it kind of shut our electrical grid down. So a lot of people were without power for a week or more, and that's gotten fixed and is better now.
Thank God for that. I was really worried because I was messaging Ishi to see how he was, and he goes, "I'm okay. I'm in Florida."
Yeah, he's in Florida. They have no problems in Florida. Long way away.
Yeah. Was it more the rural areas that were affected, or was it?
No. It could have been anybody. It was the whole state was affected. Yeah. So people down in San Antonio had problems. The weather down there is typically a lot warmer. They had problems. So it sort of exposed a lot of the difficulties or the problems with the way our grid in Texas is set up. And I hope that the legislature does something to fix it. But I worry that it's one of those things that, by the time they get around to talking about it, it'll be 80 degrees and sunny, and they'll say, this
will never happen again.
Yeah, why mess with a good thing?
Yeah, so, when hell freezes over.
Yeah. That was one of the things that I did find quite shocking, was how even back in 2010, when I guess climate change was less talked about now, but no one, like the general prevailing concept was, this is just made up. It's just not true. It's just like it's a bit of a conspiracy, and it's is the message of climate change coming through, or not really?
There's still a segment of the population that feels that way. A lot of it, Texas, of course, is a state that benefits from oil and gas revenue. So it's tough to convince somebody that their livelihood is a bad thing, right?
Yeah.
So they're going to be against that. But I really think that mostly that's a generational thing. If you talk to people that are my daughter's age, they
Totally get it.
they accept that it's a real thing and that we need to do something about it. So I think as time goes on, you'll see more and more. Texas and Texas, Louisiana, Gulf Coast states are always going to be heavily into the oil and gas business. You just got to find a way to do it cleaner.
Yeah, agreed.
So, yeah.
Adam, let's switch topics. Let's talk about your development of the pelvic and acetabular service at Parkland. So, Charlie, you and Charlie were kind of at the seat of that. But you were inventing instruments and you were building stuff in his garage, and you would, it must have been a really exciting time for you.
Yeah, the frame, as you used the frame a lot when you were at Parkland. The frame was developed out of necessity.
Yeah.
And when I was a resident and then a fellow, when we were doing percutaneous reduction of displaced pelvic ring injuries, I didn't really know, because Charlie was doing them percutaneously for my entire residency. I had never seen one done open.
Right. Okay.
So you read about it, but I'd say, well, we don't do them that way.
Yeah.
So I sort of thought what we were doing at Parkland was normal. I thought that's what other places do. It wasn't until later that I discovered that we were doing crazy stuff that nobody else was doing. And so the frame was just a way to make the job easier. And it really, there's two things that we had to have. The first, you worked with Joe Allred a lot.
Yeah.
So Joe was a UT Southwestern employee who was in the, basically it's like a intellectual property development part of UT Southwestern. And he was pretty much right away supportive of the idea behind the frame. And I think that without that, we would have never been able to do it, because we had to, it's an invention, so we had to go out and we had to get people to build the carbon fiber parts, and we needed money, and so UT Southwestern supported that.
Right.
The tools, the instruments that we made, Charlie made the originals himself in his shop, so that we could take care of in-house. But the frame itself, we had to get it made. And I found the companies that there were two. I found the first company was a company called Quintus, and they made the original prototype. And we started using that thing, and it was clear right away that it was going to work. I mean, it was awesome. We had this thing, this made up crazy idea, and it worked. And it was a lot of fun.
I was going to say, it must be real fun making your own implants.
Yeah, it was great. I mean, the tool, Peter's been out to Charlie's shop, and Charlie basically is a machinist. I mean, he could make anything you want out of metal. So I said, we need tools that do this and this and this, and they've got to attach to the frame and be rigid. And he just took home some cast off parts and made it. I mean, literally, came back to the hospital after a weekend, and there you go. And so we started using it on patients, and I learned a lot. You have to go when you're using a new invention on the patients. Of course, you have to consent them. You have to say, okay, Mrs. Jones, we're using this new thing on you. It's never been used before. Here's how it works, and here's what we think it's going to do. And the surprising thing to me was that every single one of the patients said, okay. They're very, people tend to still trust their doctor. We never had anybody say, no, that sounds dangerous. They all, just the opposite. They said, oh, that sounds like a good idea. That's what I want done.
Yeah.
So it was really a lot of fun.
So the legend of Charlie going off, making tools and stuff in his shop, making those retractors and those clamps in his shop, and then bringing them in, sterilizing them, and using them in patients. That's true. That's what happened.
Absolutely. I mean, we couldn't have done just even relatively simple things like the pig sticker. I mean, you know
Yeah.
those. That's
Yeah.
a simple device, but it's so much better than the retail alternatives. And
Absolutely.
so they, and it was funny. It was kind of a lesson for me over the long haul. So tools that you like one-off ideas, like I want to make a clamp or even something relatively complex like the frame. If it's just you doing it, then it's not that hard to do. I mean, you can do it because the hurdle is you having the energy to do it and the time to do it and the wherewithal to do it. Much harder to do is stuff that requires multidisciplinary agreement. That's really hard to do. That's difficult. Getting the frame together, it was me and Charlie and Joe, and we were all committed and we all put in the time and we sort of pushed and we got it done. But getting other stuff done is a lot tougher.
Didn't you need to go through like FDA approval and things like this?
Oh yeah. I wrote the FDA a letter. I wrote a letter.
Yeah. We're doing this thing.
Dear Joe and dear Mr. and Mrs. FDA, we want to. And it was much easier than I thought it would be. I sent them a letter that said we have this device. It's basically it's a big traction device. It's not gonna. It's a series of pins. It's not going to stay in the patient forever. We're going to use it and we're going to take it off. And so it fell under a relatively less regulated medical device category.
Yeah.
So that part wasn't that hard at all. It actually went pretty smoothly.
And did you have to apply for a patent and things like that?
UT Southwestern did.
Okay.
So UT Southwestern, it was the Intellectual Property Development Office, and so they own my brain, and so they applied for that.
I want to have I want to be. I wish I'd been at the brainstorming session where they go, "What should we call this thing?"
Well, that was a bad idea. If you ever invent anything, don't name it after yourself, because inevitably there'll be some jackass who doesn't like you.
Yeah.
And he won't use it just because it's got
purely.
Your name on it.
That's right. Purely because he thinks you're. Yeah, he's making a millionaire out of you.
Yeah. So don't name it after
It's
yourself.
funny you say that, because my surname's Akhtar, and I've always wanted to invent the Akhtar retractor, and I'm on the lookout. So if anyone listening has any ideas, I'll go 50-50 on the. In fact, you can have all the money. I just want the name. I want the fame.
Something that catchy may work.
Yeah,
that may work. The Akhtar retractor.
The one thing I just realised, we're being slightly remiss. The people listening at home, they may not know what a star frame is. Could you just summarise it for us?
It's basically a carbon fiber garden gate.
Yeah, pretty close. Yeah, it's like a giant. It's like a big X fix that attaches to the operating room table that allows you to firmly hold one side of the pelvis down, hold it still while you work on reducing the other side.
Okay.
And,
so you're clamping them to the table, essentially.
Yeah. It's so the pieces don't move around.
Yeah.
In the old days, we used to get a resident to push down really hard on the uninjured side to try to hold it steady, and of course, it doesn't work. The pieces move around, and the resident gets tired. So the frame doesn't get tired. It doesn't wear out.
I've got terrible memories of pelvic surgery as a junior doctor. I used to work with a guy called Angus Lewis, and he used to put a traction pin in the distal tibia and ask me to pull on it. So I'd have my hands on this thing, foot on the bed, and just go doing a Valsalva for like 6 hours.
Yeah, well, that used to be me. I used to have to pull on and I hated it. You're pulling on the leg and you're yelling at the fellow to get the guide wire in the right spot.
Yeah.
It was terrible. I mean, that explains now why I've got all these hernias and prolapses and things.
It doesn't explain.
I wish there'd been a star frame back then, man.
Yeah.
It's funny that you could just do that, because in the world of knee surgery, we've been talking recently about some implants, and the one thing we want, it's really funny, a lot of people want a spoon. And not a fancy spoon. They want literally a spoon that you will eat, ice cream with on the set for meniscal repair. And there's a hassle getting hold of a spoon. I wish we just go to America, sterilize what you want out of the shed and stick it in.
Well, I don't think you could do that nowadays.
Well, if you build a tool now and you want to use it, you have to have a sterilization protocol. So the people in SPD know how to sterilize it.
Yeah.
But even that's not that hard. There are companies that you can send stuff off to, and they'll say, okay, you need to, run this at 170 for an hour or whatever. You can get it done.
I was just going to say about the about inventing your own stuff and being a pioneer of a new technique. It wasn't. When I came to Dallas, I remember distinctly being warned in advance that Adam and Charlie were up to something down there, and that they were maybe not to be trusted
in their workshop.
And having got there and kind of discovered it, I also got that feeling when you're looking from the inside out that I just didn't feel that there was a sense that the establishment, the OTA, if you like, but an establishment of orthopedic surgeons had almost closed the door on you a bit. Is that fair, or am I overplaying that?
Yeah, no, I think that's really true. I think we learned a long time ago that I mean, if you do crazy stuff, by definition, it's crazy stuff, right? So
yeah,
we learned a long time ago that you can't really convince people of techniques, safety, and utility through a paper or an OTA presentation. I mean, you especially when it's something that's really radical.
Yeah,
I mean, it just doesn't work. So the only way to do it is to train people kind of, one at a time or two at a time, and then they act like apostles. They go out and they carry the discipline out there, and they show, hey, this is not crazy. This is reproducible. You can teach people how to do it, and we're going to do the patients a lot of good. And I think that's really what we've done. And Charlie and I used to talk about it's hard to get stuff into the OTA. It's hard to get stuff published in journals when it's crazy. And after a while, you just kind of quit beating your head against the wall and just rely on training people.
Yeah.
And that works okay. You have to spend, you have to be willing to put in the time. You're teaching one guy a year, right?
Yeah.
And if you're lucky, the guy does what you've done, and he goes out and then he carries the word out, and then he trains people. So you sort of pollinate the globe, doing it that way. And that works out, and I think that's probably a safer way to do it.
Yeah, it's like the gospel according to Starr. So basically, you're like the Jesus Christ of pelvic and acetabular surgery.
Yeah, that's bad. Don't say that either. That's
not in Dallas.
Yeah, it's all
bad.
No,
but you've got to have. I mean, it gets back to the apprenticeship thing. You bring people in and you teach them a craft or a set of skills, and then you release them and you teach them how to do it safely. Yeah, and that works. That's a tried and true way to do things.
Yeah.
So that's what we've been doing.
And without sounding like an infomercial, which this is not in any way, it's now available in the UK, isn't it?
Yeah.
It's got CE mark.
Yeah. David Plain markets it over here. Yeah.
Plano. Okay.
Yeah.
Awesome.
Yeah.
And so the resistance you got from just to go back to that point about, the orthopedic establishment not really accepting the crazy stuff, do you feel like you're someone who has always kind of railed against the establishment, has always been a bit of someone going slightly against the grain, or did that sort of take you by surprise that you suddenly found yourself in that somewhat contrary position?
I think that it's I don't know. I mean, it's hard to. I'm not that objective about probably I am. I can tell you that, like I mentioned earlier, when you coming up with crazy surgical techniques that work in your hands, I think that probably happens quite a bit. People probably come up with ways to do, I've got a really good way to do an outside in meniscus repair, something like that, but they don't spread it. It doesn't spread, so they never get beaten up by their colleagues. But if you try to do stuff that is like the stuff I'm working on now, that requires multidisciplinary action, that is much, much harder. You can't. It doesn't matter if I'm able to do it. It doesn't. That's not the goal. What you're trying to do is get other people to buy into an idea and then work with you.
Yeah.
I'll tell you, I learned a lot. The mistakes I made initially were just trying to browbeat people. You're doing it my way. You're going to do it my way, and they'll just tell you, no, we're not. I'm not doing that.
Yeah.
But the funny thing was that, like the pulmonary embolism thing, we have this app that predicts risk of PE.
Yeah.
And setting up a protocol to make use of that app, I was really sick of having patients, get sick or die from PEs. And in the ortho trauma population, it's not rare at all. We were getting like one a month.
Yeah, absolutely.
One PE a month. And I was arguing with the general surgeons, and we're fighting with them about this stuff. And finally, we sort of came to a collaborative agreement, and it wound up being so much better because those people were really smart. They thought of things that I would never have thought of, and they had their own take on what we should do, and it wound up making things better. It wound up being better. So I think if I've learned anything over the years on doing new stuff, it's that. I mean, if it's something that involves just like me and Charlie or me, that's pretty easy to do.
Yeah.
It's just me. I don't have to worry about, I don't care, if Dr. So-and-so in Minneapolis doesn't think this is a good idea, well, so what? But if you're trying to do stuff that's multidisciplinary, you've kind of got to have buy-in.
You've got to take them with you rather than impose it upon them.
Yeah. Now listen, I'm not a pelvic surgeon. The resistance, was it the fact that you weren't basically opening them up, stripping it down, and getting it completely anatomical, and that it wasn't keyed in like a jigsaw before you plated it? Is that the resistance or something else?
No, I think plenty of people were doing percutaneous pelvic. The percutaneous posterior ring fixation was pretty well established. I mean, Chip Rout had done a lot of work on that, on popularizing that and showing that it was effective and safe. Mata published on it early on, but then Chip, you've got to give Chip credit. He was probably the guy who spread it, and he wrote it up and was critical of his own results. And so he had established that as a viable technique before I started publishing on it. The frame, I think the resistance to the frame just was that it was just so out there. I mean, we were doing LC2 screws and anterior column screws and this stuff that was just kind of nuts. I'll never forget, we were at a meeting and we were presenting some people that we put anterior column screws in them, and that was probably around 98, 99, and guys are throwing tomatoes at you. You put those x-rays up, they're like, oh my God, you can't do that. That's so dangerous. And Alan Jones was working at Parkland at the time, and Alan said, in 5 or 6 years, this will be dogma. Everybody does it. And he's right. I mean, now it's very, very common. Anterior screw fixation.
Absolutely.
People do it all over the place. It's nobody bats an eye.
Yeah. It's funny because I just remember putting pelvic X fixes, on sawbones with a bin bag over it, and it's quite easy to, there's not much room for error, is there?
No, there's not. No, they're fairly narrow channels, but at the same time, and I think with percutaneous pelvic stuff, the expertise, a lot of it is just about really, really understanding the radiological views and getting really, really accustomed to that. And one of the things that you see when you go to a place like Dallas is you see radiographers who are, they could put these screws in easily. They just know the view and they just know their machine. If you try and touch that machine, oh my God, they basically use it like a weapon. Like Joe would whack me in the shins if I try and touch it. Get off my machine.
We're really spoiled at Parkland. We've got the best X-ray techs in the world.
Yeah.
Those guys are studs. So we're lucky.
What's next what's after the Starr frame? What's coming next? What are you working on?
Well,
Is it a secret, or are you allowed to tell us?
Well, some of it's kind of secret. But we're working.
No one's listening. There's just us three here. It's all good.
We're working on this. If you guys are both ortho guys, and so if you have a patient who comes, say you have a guy who has a femur fracture and a closed head injury, say he's a 27-year-old guy in a car wreck,
Yeah.
femur fracture, closed head injury, maybe a splenic laceration,
Some rib fractures,
really, really in bad shape. You know, say his ISS is 25, whatever. And so our belief, our faith, our foundational belief is that early fixation of the femur fracture is beneficial because it cuts down pulmonary complications. We really believe that strongly. There's good data to support that idea. But there's a whole.
It's what we think as well, right?
Yeah.
We're keen to nail them as soon as we can.
Sure. But there's certain populations where you probably shouldn't do that.
Yeah.
And Chris Pape has done as much as anybody to sort of explore that. And so Pape's idea is that there are certain people who are in a borderline category that you should either do damage control only, or if they're an extremist, sort of do nothing. And the problem that if you go to an orthopedic meeting and you ask people, well, how do you tell whether it's okay to take the patient to the OR, and how do you judge whether you should do damage control or nothing?
Yeah.
And people will say, well, I'll use lactate,
That's what I was going to say. Yeah.
Base deficit, but that's like what are we doing? It's very, very gross. They're very gross, and the ability of those measures to predict mortality is not that good. So what we found, we've been working on this for years now. What we found is that and Pape has these little formulas where you try to use certain variables like age, blood pressure variables, lactate, things like that.
Like an algorithm.
You got to calculate it by hand. You're supposed to carry around like a card in your wallet, and then you
like a possum score type thing.
And you say, well, who does that? Nobody does it.
No.
Nobody does it. You just rely on lactate. So we've developed this app that lives in Epic that does it for you, and it uses about 20 variables, and it updates hourly.
Is it called the Start app?
No, I
just
learned
checking.
It's called a PTIM, Parkland Trauma Index of Mortality, and the fucking
Parkland,
thing works.
baby, Parkland.
Yeah, I know. Yeah, you gotta, but it works. I mean, it'll tell you whether the patient's going to live or die in the next 48 hours.
Right.
It's really cool. So we use that to say, okay, Mrs. Jones, we shouldn't touch her. You know, if her score is high, I would say, leave her in the ICU, let her get resuscitated. Or if she's safe, we say we're good to go. And so that's because Parkland was the institution that did the first prospective randomized trial on early versus delayed fixation of femur fractures.
I didn't know that.
So I've been hearing this stuff since I was a med student. This dogma, and now I think we have a way to do it with more precision. Yeah. So it's really neat. It's cool.
Yeah, that's awesome because it is still a problem. We had I remember a young guy, only a year or so ago. Bilateral femurs. And bilateral femurs is often one of those tricky ones where if it was just a unilateral femur, you just crack on and nail it because his lactate was okay. But you do one femur, and now do you do the second one as well? Yeah. And then we did, and then he went on got a horrible fat embolism, and he's never been the same again. And he survived, but he's not right. And it was almost certainly that second nailing that did it. And you do wonder, or you just kick yourself and think if we just X-fixed him or just left him in traction and then done it like 3 days later, he'd probably been all right.
So hopefully you'll be able to give us the answers then and say, well, look, at this score you shouldn't go in, at this score you should go in.
But Adam, how do you prove it? How do you prove that your algorithm actually works? Because that's tough, huh?
We've proved it we've got data on thousands of patients. We've been the development study. Relied on thousands of patients, and it's been in use at Parkland now for more than a year. And so the predictive power of the score we're good with. I know that it works. It can tell you. The neat thing is that the variables that the score uses are pretty much the same ones that Chris Pape and Heather Villiers and other people have latched onto. So it's not like we're inventing some new, this physiology is what you need to focus on.
Yeah.
It's the same thing. The beauty of it is you don't have to do anything. You turn the computer on, and it's there. It lives in Epic in your EMR, and so it tells you, and it lives with the patient. So if you correct the ventilator settings and you make the patient better, the score will get better. If you correct anemia, the score gets better.
Right.
If their potassium
Right.
is low, you can address it and their score gets better.
So Epic's your kind of electronic health record. If you don't have that, then how do you work out the score? Is there an app or something you can do?
We haven't built a freestanding one. We've been talking about that for hospital systems that don't have EMRs. In the U.S., pretty much every trauma center is going to have an EMR.
But they may not have Epic though, right?
They may not have, but the app will work in other EMRs. Okay. It'll work. There's a couple of them on the market, Pepsi, Coke, Dr. Pepper. It'll work in any of them. Yeah. You have to tweak it a little bit, but it can work.
Given that you're well known for percutaneous stuff, are you getting into robots and navigation?
No, we tried that. We tried navigation years ago with the Stealth system. I don't know if you guys have ever even heard of that one.
No.
The neurosurgery guys use it a lot for pedicle screws, especially in the C-spine. It works pretty well for pedicle screw placement, but they didn't work very well for fracture reduction, because when you shift the bones around, then you have to re-register, and it's kind of a pain in the ass. It really slows you down a lot. But I think that's probably, I'm very hopeful that we'll get better intraop imaging. I think that's clearly coming. We have a Zyme, a C-arm that'll give you essentially like a 3D or a CT rendering using just fluoro, but it doesn't fit over the frame very well. Pete and I were talking about this before. Pete says he can squeeze in the top of the frame and get it to work. We haven't done that yet, but I think that's kind of the holy grail for assessment of reduction.
And generally, your patients are a lot bigger as well.
Yeah, they're much bigger. Yeah, I'll tell you, when I went to the UK years ago,
it was like the land of the undernourished.
Yeah, your registrars drugged me out to some bar or some pub, and one of the guys looked at me and he goes, "You're the tallest fucker in the building." And I said, "Yeah, but, I can't help it." But yeah, Pete could tell you, we've got some whoppers down here, some really big people. A BMI of 30 that's nothing. That's nothing. You're not even in the game. You got to get 30.
In some places in the UK, you can't get a hip replacement or a knee replacement if your BMI is over 30 because you're too overweight. You have to lose weight first and then come back. Yeah, whereas you've got guys in their 70s, haven't you? I heard.
Oh yeah, it's crazy.
Adam, tell us about the change in case mix that you've seen in your trauma. In the UK, there has been a slow but steady drift towards more and more osteoporotic, less and less high energy. It's not been dramatic drop in high energy, but there is a massive increase in fragility trauma. Is that the same with you guys?
Yeah, it's not to the degree that you guys experience. We see the average. The only thing I can look at that's concrete is the average age of my patients. And so the average age about 15 years ago was about 38. The average age now is about 40, 42, something like that. Okay. So they are getting older, but we still get a lot of high energy, motorcycle wreck, car wreck. I fell off a scaffolding, that kind of thing. Yeah. Going to Norwich as a senior resident was a big shock, because I went over there, and in Norwich you do 15 or 20 neck of femur fractures on a weekend. It was just like a stream, and it was great for us because I'd never, we didn't see anywhere near that many in Dallas in '90s, but in Norwich they sure did.
And you've published a fair bit on augmentation, haven't you? Well, it's been an area of interest for you, isn't it? BMP, things like this.
Yeah, Parkland was one of the centers that was involved early on with BMP, and it looked really promising initially, but then we started, you put it in and it created this big edematous inflammatory cascade, which I guess was good for fracture healing, but it makes the wounds look like shit, and so everybody was worried about infection. And so we kind of got scared off by it. It wasn't as popular as you would think.
So you're not using anything now? No magic fairy dust now?
No.
Okay.
No.
No.
What another thing you got into while I was there was the psychological side of trauma. Because I often see, I do a few medical reports on patients where you're seeing people, 2-3 years down the line following their trauma, and they've had a bunch of injuries, their femur, the tibia, and their, maybe had some rib fractures, etc. And maybe they didn't have a head injury, but boy, the thing that's bothering them now is not their femur. I mean, it aches a bit, but it's not. That's the thing that is absolutely killing them is their post-traumatic stress disorder, or the psychological manifestations afterwards. Are we moved forward in that at all, or are we still just obsessing over reductions?
No, I don't think we've moved on that at all. I think we still obsess over reduction, and it's a shame. I think obviously there's two ways to look at it. I was at the OTA a number of years ago, and Joel Mata was the keynote speaker, and Mata got up there and said, basically, it was a great talk, but he basically said, the only thing I can affect is the reduction. That's my job. That's what I'm there to do. I'm there to, that wasn't the entirety of his talk, but that was one of the key things that he said. And I think that's a valid, that's a valid standpoint. It's like talking to somebody about politics and they say, the only thing I'm interested in is low taxes. I want low taxes. I don't care about, okay. Yeah. All right. I may not agree, but okay. I mean, at least I understand that's a valid viewpoint. But the thing that, if you're in this business any time at all and you scratch the surface even a little bit, it's going to come out. It always does. And it's such a huge part of the outcome for the patients that if you don't address it, even, as best you can, the patients really suffer for it. There's no question that it has an enormous impact on their outcomes. Nobody debates that anymore. It's just a question of do we have a way to help them? In Texas, the rate of uninsured patients is sky high. It's 1 in 4 people will be, so they essentially have no healthcare access at all unless they go to an emergency room. And really in the ER, there's no such thing as, unless you're suicidal, you can't get psych ER care. It doesn't exist. Yeah. So for a lot of our patients, we don't have anything to offer them, which really sucks. But you put them on give them some Prozac, give them some sertraline, something like that, and try to make them better. But it's really a tough problem.
What was the outcome of your study into that, looking at antidepressants, almost treating them primarily?
It helps. It makes them better. It doesn't. The problem we had at Parkland, as you might imagine, was the follow-up. The follow-up in the study was kind of poor. Yeah. But they do get better. Their symptom scores, the way the psychiatrists assess efficacy of PTSD treatments is they look for, did the symptom scores drop? And you can drop their symptom scores if you give them meds like sertraline or Prozac. There's a lot of meds that have been approved for use for PTSD. You can drop their symptom scores. And it doesn't have to be, they don't have to be on it forever. You don't use it, it's not permanent. You just put them on it for, 6 months, a year, or something like that, and they tend to get better.
I must start using that for my arthroscopies then. Thanks for that.
It's pretty traumatic.
But are they having any talking therapies with that? CBT, things like this?
Yeah, we considered CBT, EMDR, there's a lot of things that the psychologists do that also work. There have been prospective randomized trials of CBT that show efficacy that lower symptom scores, but it's really it's expensive to hire a bunch of therapists, and it's hard to be sure that, like, for a study, is there, you got therapist X and Y, are their CBT sessions exactly the same?
Yeah,
and the
sure.
answer is no, they're not. Whereas a Paxil tablet, it's always the same. Here's your Paxil. It's always the same. So when we designed the study, it was easy decision to use the meds instead of the therapist.
Yeah. Understood.
Yeah. Adam, tell us what it's like to be chairman. What's it like being the boss? Is it pretty wearing? Is it a reluctant leadership, or do you kind of like it?
I was the interim chair at UT Southwestern for about 4 years, and I'm the chief of orthopedics at Parkland now. So the the chairman of our program now is a foot and ankle guy named Dane Wukich, and he's a good guy. He's even keeled, honest, so that really helps. I think for me, it wasn't that much fun. I mean, if you're honest with yourself, you say, why do you like doing what you do? It was the surgeries were fun, the research is fun, and the teaching is great, right?
Yeah.
Being the chairman takes away from all of those.
Yeah.
Takes away from all of those. And Charlie told me that years ago. And my dad was the chairman of internal medicine at Scott and White for more than 20 years. And he told me the same thing when I was in college. He said, beware of administrative jobs because they take away from the reasons you go into medicine.
All the fun stuff. Yeah.
Right. And we've got to, I mean, there's no question. We all bitch about administrators. We all gripe about the administrator and the departmental chair. It's normal to gripe about your chairman, I think. You've got to have good ones. But I probably was not well suited for that because I'm not that interested in it. I'd rather think about fixing pelvises or, how do I do this or how do I do that? I could kind of give a shit about the, our press Gainey scores or whatever. So it's but there are people who are really good at it, who are suited for it.
Yeah. I appreciate your honesty. Pete was our clinical director for the last few years.
Yeah.
There's no dig coming. He's thinking I'm about to take the piss.
God, here we go.
No, I'm just saying, how did you find it?
Exactly as Adam describes. Exactly as it's. Again, I don't think I was particularly suited to it either. And it's easy to be a leader because you kind of grow into that. So you can do the leadership thing, but actually making good decisions on behalf of the department and making good strategic calls and stuff, and also some of the day-to-day, actions and things. They're often easy to procrastinate, easy to make lazy things that just suit you rather than suit the wider department. I think it suits certain personalities and not others, and every aspect of it does detract from the reason the bits that you find fun, which are the operating. And for me, and as for Adam and Charlie, it's always been the apprenticeship of trainees and fellows. That's the main joy of the job, I would say.
It didn't help, Adam. It didn't help that Pete was the ultimate shit magnet. We had we had multiple terrorist attacks. We had the cyber attack on the NHS. We had COVID. Literally
COVID times two.
Literally there was like a whole century's worth of disasters in his 3 years or something.
Yeah. Take Pete out back and shoot him. So
that's right. Put him out of his misery.
No, I really think that's really true, and I think a lot you see young academic orthopedic surgeons kind of get trapped in that idea that I have to follow a pathway that leads to chairmanship, and you don't. I mean, you in fact, unless you have a real desire to end your career that way, I would say you shouldn't, because it's just not for everybody. I mean, I've known some really fantastic chairs at various surgical departments here at UT Southwestern, but I think that's a job that you got to think long and hard before you decide to do it.
Yeah, not many people have a real genuine aptitude for it, do they?
No,
I would say.
Yeah.
No.
That's refreshing advice, because often you get, the advice is, push for it. You want to be the chair. You want to get the top.
Or it becomes processional. Like, I'm doing it for these 3 years and you're taking over from me. And neither of us are going to be particularly good at it, but we're just, it's our turn kind of thing. I think you guys are better at that, aren't you? Because you actually have in the US, you have a genuinely competitive, it's financially remunerated. So you get a bit of a competition going on for these chair posts. But nonetheless, but people have to be doing it for the right reasons, don't they?
Yeah, it's hard to get good guys who want to be a chair. There's a lot of reasons to avoid it. There's a lot of headaches. There's a lot of stuff that you got to put up with. It's a lot like politics now. I mean, you're set upon from all sides, and you're trying to please multiple people, and it's not an easy thing to do.
And you may have to deal with badly behaving orthopedic surgeons, which can be really quite challenging.
Every day.
Yeah.
So the HR part of it is the hardest part of it by far.
It's just interesting because we had Mohit Bhandari was on, one of our guests recently, and he was a chair of Mac Ortho, now he's a chair of surgery, and he's certainly someone who's got an aptitude and I think a desire to do that. So you're right, it very much depends on your personality and your kind of drive.
Yeah. I mean, it's one of the a fantastic chairman here at UT Southwestern is the chairman of the ophthalmology department. And he said the best thing in the world for a surgeon was to have a good chairman, right? And it's just what Pete's talking about. If you can make decisions that are based not so much on benefiting me, but benefiting the whole group, that's really that's awesome. So if you have a chair like that, lucky you. But those people are tough to find.
Listen, it's been a pleasure to see you again, to talk to you again. Thank you for coming on.
You bet. Y'all have a good rest of your. I guess it's 9 o'clock there almost.
10 to 8, almost 8 p.m. Yeah.
Time to go out drinking.
All the pubs are shut. It's lockdown.
It's total lockdown
really?
here. Yeah, you can't get a drink for love nor money.
We're gonna have to just drink. We're gonna have to drink on our own in here.
Texas has been released from masks, haven't you? You don't have to wear masks.
Yeah. We've been free to go for months now.
That's great.
There's a Finnish word for drinking in your underwear. Is that what y'all do over there?
Pretty much, yeah.
Yeah, that's it.
Yeah, I'm wearing nothing but my Parkland cap, and Pete's got his Parkland t-shirt on, and we're just making merry.
Gross.
Listen, sir, thank you very much. It's been a pleasure.
You bet. Y'all take care.
Look after yourself.
Cheers, Adam.
See you later.
Pete, I'll see you next Tuesday.
As ever.